Thank you, Mr. Chairperson, for nice words of introduction. And thank you, Manoj and Purvi, for inviting me to this DRS meeting. Topic for today's discussion is diabetes in elderly. I understand that it is too late in the evening, but still the study must go on. What we need to know that diabetes is highly prevalent health condition in elderly population. Over 29% of people over the age of 65 years, that is the age for elderly, are suffering from diabetes, and one half, that makes it another 50%, that makes it 80% are suffering from diabetes or pre-diabetes, and number is expected to increase in coming decades. It may be type 2 diabetes in elderly, or type 1 of childhood, or adult onset of type 1 diabetes may be seen in elderly population. It's a functional diabetes in elderly do have functional disability. They have cognitive impairment. There is sarcopenia or accelerated muscle loss with so many reasons behind it. There may be mobility impairment and frailty. Other than this, diabetes in elderly may have comorbidities like hypertension and CKD, CAD, stroke, and premature death in elderly population with diabetes is very common. We need to understand that we don't need the diabetes treatment only in this elderly population. That must include psychological aspects, that must include functional aspect, that is the self-management abilities, and the social aspect of diabetes in elderly. While assessing elderly diabetic, it is important to know the type of diabetes, what is the duration of diabetes, that is very, very important, and presence of complications. What complications or target organ damage is already existing in this elderly population, and we know that hypoglycemia fear can be there. Screening for complications in elderly should be individualized and periodically revisited, depending upon various reasons for it. Now, recently, ADA 2025 has said 4M framework for elderly diabetes population, that includes mentation, medication, mobility, and what matters most for elderly diabetic. Elderly diabetes, we need to impart self-management training that may include family members or the person himself or the caregivers are important. Essential points to keep in mind are hypoglycemia, neurocognitive dysfunction, various geriatric syndrome, which I will enumerate just now, benefits of medical nutrition therapy and physical activity are still there in elderly population, and medication review on time may be earlier than what we do in younger population, and evaluation of complications like cardiac, renal, neuropathy, or foot complications. Various geriatric syndromes associated in elderly with diabetes that affect treatment and quality of life, may be polypharmacy, frailty, injuries can lead to fall, the fall can lead to injuries, the fractures can be there, disability and or persistent pain may be there, urinary incontinence in elderly population, whether it is male or female, is quite common. Type 2 diabetes is very common, as I said. Cardiovascular disease, cognitive decline, and depression because of various social and cultural issues may be found in elderly with diabetes. What are the general principles of therapy? Elderly are at increased risk of hypoglycemia, so we must use medication with lower risk of hypoglycemia, which is preferred. I don't say that don't use drugs which cause hypoglycemia, but preferred drugs are those with less common hypoglycemia. Overtreatment should be avoided. De-intensification or simplification should be done. Cost of care should be taken care. And two important issues in elderly with diabetes are neurocognitive dysfunction and hypoglycemia risk. And we know that elderly with diabetes are at increased risk of cognitive decline. Identifying cognitive impairment, it may be minor, that is important. Impairment may range from subtle dysfunctions to memory loss to dementia. Diabetics have higher incidence of all cases of all causes of dementia. It may be Alzheimer's, vascular dementia, then non-diabetic counterparts. Poor glycemic control leads to it. Longer duration of diabetes leads to neurocognitive dysfunction. Challenges for clinician may be increased with cognitive impairment. Cognitive dysfunction may make it difficult to perform glucose monitoring and adjusting insulin dose. That is very, very important. It also hinders to maintain timing of meal and content of diet. It is important to simplify drug regimen and engage in various support structures. Screening for early detection of mild cognitive impairment is very, very important, and the level of evidence is B. And hypoglycemia, there is increased risk of hypoglycemia because of various reasons, including insulin deficiency, which leads to insulin therapy, and progressive renal insufficiency in elderly population. Elderly population may have unidentified cognitive impairment. Glucose monitoring and insulin dosage may be forgotten by elderly population, elderly diabetic. Severe hypoglycemia leads to increased risk of dementia because of several reasons. To mitigate hypoglycemia risk is to see whether the patient is skipping meals or inadvertently repeating doses of medications. And it is very important that type 1 diabetic in elderly population, CGM should be done to reduce the possibility of hypoglycemia, and the level of evidence is A. Now coming to treatment goals for healthy elderly population with diabetes, these are the various things that we should look for in elderly diabetic population, healthy with longer life expectancy, but elderly, the A1C should be between 7 to 7.5, maybe less than 7. Time in range, 70%, TBR, less than 4%. Fasting or preprandial glucose should be between 80 to 30, 80 to 180 is bedtime glucose, and blood pressure is less than 130 by 80. And statin should be used unless contraindicated, and that is intermediate elderly with diabetes. Intermediate means variable life expectancy and individual preferences of family members or elderly population. The A1C goal should be less than 8. TIR, TBR, fasting, bedtime glucose, and blood pressure are mentioned there. Statin are important unless they are contraindicated or not tolerated. For poor health, elderly diabetic, poor life expectancy, avoid reliance on A1C. CGM should be avoided, reliance should not be there. Fasting or preprandial glucose should be between 100 and 180, bedtime between 140 to 200, and blood pressure less than 140 to 90, and consider risk-benefit ratio with statin use. Now coming to drug therapy for elderly diabetic, obviously metformin is the first line agent because of various reasons, but we must understand that it is contraindicated in patients, elderly patients with renal insufficiency, especially it is EGFR more than 30 should be there to start metformin. Metformin should be used with caution in patients with impaired hepatic function, heart failure because of risk of lactic acidosis. It should be temporarily discontinued before procedures. During hospitalization, metformin can cause GI side effects, reduce appetite, reduction of or elimination of metformin may be necessary for patients experiencing persistent GI side effects. Elderly taking metformin should be monitored for B12 deficiency. DPP-4 are clearly not causing hypoglycemia. They should be used as second line agent. Insulin secretagogue may be used in selected cases. SU with shorter duration of action such as glipizide are preferred. TZDs should be used very cautiously in elderly patients, especially those who are already on insulin therapy because of various risk of heart failure, osteoporosis, falls or fracture, or bacular edema. SGLT2 inhibitors are useful, as Unni has already told you. They are oral, convenient for elderly population, established risk of ASCVD or at risk of ASCVD, heart failure and CKD. These drugs have shown benefit, and analysis of various trials done with SGLT2 inhibitor show that older patients may have similar or even greater benefit than younger population. Side effects are many and they should be looked after. GLP-1RA, CV and renal benefits are there in elderly population also. Meta-analysis of GLP-1RA trials, these agents have been found to reduce major CV events, CV death, renal benefit, stroke and MI in patients above 65 years of age. These are injectable agents with exception of oral semaglutide. Weekly dosing schedule should be utilized properly. It may reduce burden of administration, and GLP-1RA should be avoided if there is constipation, gastroparesis, recurrent ileus or bowel obstruction. This is a recent article on 16th of August 2025 in Journal of Nutrition, Aging and Health, which shows that sarcopenic obesity in elderly population may be problematic, especially if you stop GLP-1RA, highlighting the need for raising awareness and preventive strategies. We may use resistance exercises, increase protein intake, and that may improve muscle mass during weight loss. Insulin is used in all type 1 diabetics and those type 2 who are uncontrolled in elderly type 2 diabetics who are uncontrolled on oral drugs. Good visual acuity and motor skills and cognitive ability is a must. Insulin therapy relies on, just 2 minutes more. Insulin therapy relies on ability of elderly to administer insulin on their own. Individualized glycemic targets should be used. Avoidance of hypo is very important. Once daily basal insulin of analog variety is reducing hypoglycemia. Long-acting analogs may be helpful in that. Multiple daily injections of insulin may be too complex in elderly with diabetes. Caregiver must apply approach to simplification of insulin regimen. So this is about simplification of complex insulin therapy in elderly population. Patient on basal or prandial, we must try to simplify it. Patient on premix, the goal should be individualized, and do not use rapid acting or short acting insulin in the evening. End of life care, this is the last slide. Strict glucose blood pressure control are not necessary in elderly with end of life care. Simplification, lipid management can be relaxed. Primary goal for diabetes management at the end of life care is overall comfort, prevention of distressing symptoms of diabetes, and preservation of quality of life. Thank you very much.